Hello everyone, my name is Nagel Desai and I'm going to go over pituitary disorders here in this section of the NAPLEX review course of endocrinology. Um, there are some interesting mechanisms in this review that I'm going to discuss here, um, particularly with this particular uh, disease. Two main parts I wanted to talk about are the pituitary anterior and the posterior pituitary. They do have different types of hormones released depending on like which side it's coming out of. Um, you can see here the anterior is mainly like reproductive and hormones mainly, and then the posterior has other types of hormones. Um, and these are all listed here for your reference. And then these are some of the other disease states I have listed here. Take a look here, some of the other medications you may or may not have seen in practice. Cabergoline, bromocriptine. I particularly haven't seen them used, but maybe they are used in some other practice somewhere else. And you probably may have seen desmopressin used for like diabetes insipidus, um, things like that. Some of the medications aren't really used in some disease states, especially since their surgery is like the first line therapy for these. Um, at least that's as per the information that I have. Um, and then we'll take a look at Vaptins as well, as that relates to the syndrome of inappropriate ADH. So these are some medications that I'm going to outline um, in this whole presentation. Cabergoline um, is an example of a D2 uh, receptor agonist. It just mainly just binds to the D2 receptor inside the pituitary gland where the lactotroph cells are located. And what happens is it just mimics that, and so it can decrease the prolactin secretion, restore normal reproductive function, um, and shrink the tumors as well, prolactin secreting tumors. And then the octreotide mechanism. Um, this one is an interesting one because once it binds, it's actually in block. So, like you can see, the hormones can release from the um, cell, but normally, but if the octreotide is bound to the somatostatin receptor, then it's going to prevent the hormones from getting out of the cell or being released. Um, and so these receptors are typically found on the pituitary cells, neuroendocrine tumor cells, GI tract cells, pancreatic cells, blood vessels in the GI tract. So you can see that too. You can probably see that in this diagram as well. This one I just pulled it out of one of my shorts, so just so we don't have to rewrite this mechanism again. So just take a look at that. It does suppress growth hormones, TSH, insulin, glucagon, vasoactive intestinal peptide, all of that. And the serotonin release. Serotonin has many different roles. I was looking at one of the other mechanisms serotonin has with like platelets and all of that. So you can probably connect some of these things with other types of diseases as well. So just looking at some of these mechanisms, you can see how they can work in other systems as well. Also decreases gastrin and pancreatic secretions as well. So, and pancreatic secretion, I mean pancreas especially, insulin, glucagon. Someone who has diabetes should be very cautious in this case because it does decrease insulin so release. So that's another interesting concept relating to the pituitary mechanism. Um, so just be aware of that. And then pegvisomant is another medication. It just This is where the differences are. It binds to the receptor inside the liver, the growth hormone, the GH receptor. It doesn't prevent the release of the GH hormone, so it actually prevents the action of it. So that's what it does here. And then desmopressin mechanism. This one is once the ADH, normally when ADH binds to, or when ADH is released from the pituitary, it binds to one of the V2 receptors, which are located in the kidneys. And that will allow the collecting duct to have aquaporin, so water can get reabsorbed and make the urine more concentrated. But when ADH is not available, or ADH is damaged, or it's not released, then it won't bind to the V2 receptors, and then it might cause massive polyuria or just basic water loss. So to replace the ADH, there's a synthetic ADH analog, which is known as desmopressin. And that's actually used as like a replacement to bind to the V2 receptors and allow the urine to be more concentrated and water get reabsorbed. So that's essentially what happens here. And then the vaptins is where, like, there's two types of vaptins. There's tolvaptan and convaptan. The convaptan binds to the V1A and the V2 receptors. Now the V2 receptors can be in the kidneys or the blood vessels. V1A is normally like in the blood vessels and other parts as well. But the tolvaptan just primarily binds to the V2 receptor. And this works the opposite to desmopressin. Desmopressin makes the water more concentrated, or the urine more concentrated. Vaptins prevent the urine from being more concentrated and causes more of a water loss. So that's what's occurring here, and that's pretty much the difference there. So just note that in case there's a patient case on this.